Good morning, Kansas City. Welcome back to our media room here at the University of Kansas Health System and our presentation where we try to answer questions about the COVID-19 crisis on a regular basis. To my right is Dana Hawkinson, our medical director of infection control and an infectious disease physician here, and as we dubbed him yesterday, Dr. Hawkeye. On the left is Michael Kennedy. On my left is Michael Kennedy. Michael Kennedy is our Associate Dean for Rural Medicine here at the University of Kansas Medical Center and Health System. I've known Michael for, a very long time, approximately, I think, probably longer than either of us want to admit.
Sure.
A few statistics this morning. I think we have 33 positive patients here at the University of Kansas Health System, actually down slightly from yesterday. The first question that I'm just going to ask as we start off our morning is, Dana, are we already bending the curve, or is it too early to say that?
I would say that it is still too early to say if we are truly bending the curve. I think we still need some more data. We'd like to be optimistic and hope we are, but I think we still need to kind of wait and look at the numbers and see what they say.
Yeah, and I think by this time next week we'll be a lot smarter than we are today.
Absolutely.
I like to look through these numbers with kind of rose-colored glasses, which I'm accused of, and which is true. But in an abundance of caution, we're not going to get out in front of that and say, oh yeah, we're really bending the curve. So our social distancing is working. I mean, it's encouraging. We do know that the percent of positive tests we do in the public is inching up. It started around 7% of all tests were positive. Now we're up to about 10% of tests being positive, which is a sign of more community transmission. So that wave could still come. If it does come, we expect the wave to be at the end of April, early May. And next week, hopefully, we'll start talking about a little bit more modeling. We are actively involved in a lot of that with our School of Pop Health, the Governor's Office, KDHE, and other national organizations that have allowed us to get a picture of Kansas. And what I can tell you is that picture of Kansas is absolutely muddy right now as far as what the rise will be. And the same thing is true for Kansas City. In the meantime, we're working hard to get everybody prepared and ready for that. Michael, one of the things I know that is coming about in the discussion, and if you could just tell us a few things about a special announcement from the School of Medicine and things we're trying to look at around our graduating students.
Yeah, so we put together a program called Kansas Pandemic, it's too long to memorize, Kansas Pandemic Volunteer Healthcare Workforce. Basically, it's the senior medical students wanted to help, and we looked for ways that they could help, and through early graduation, if they've completed their degree requirements, then we can get them a special permit in Kansas, and then they can work alongside a practicing physician. So far there's been 52 students signed up.
That's great.
Isn't that amazing?
That is amazing.
Wow. And it actually kind of brought me to tears a little bit when just the flood of emails to the reply.
Yeah.
So the program will help with this surge capacity. We're trying to time it for mid-April through end of May, and that way the students can really help out and still make it to their residencies on time.
That's great.
Wow.
And I think this was a kind of a brainchild of a lot of people. Well, one of the folks who gets credit for that is former governor and physician Jeff Collier.
Yeah.
And Jeff, are you on the line with us now?
Yeah, I am.
So Jeff, talk to us a little bit. How did this? Where did this get started? And as both a practicing physician and as a practicing politician, is that a fair statement? Still, I don't know.
I'm definitely not a practicing politician anymore.
But Jeff, this is a great thing, and thank you so much. Yeah. And as I remember, you've got deep ties to the University of Kansas Medical Center and being a medical student here.
Yeah, so I graduated in '86, and I'm an associate professor in the section on plastic surgery here at KU. So I touch base with our residents and have patients there as well, but on a small scale. The conversation actually was actually 2 weeks ago today.
Yeah.
Was with Chancellor Girard, and I called him, and then also with Dr. Samari, the head. And, we're clearly going to need surge capacity, and medical students had just gotten their match papers. That's when you that's when you find out where you're going for your residency on July 1st. Sometimes they just start drinking for the next couple of months.
Yeah,
We don't encourage that, by the way, just to be clear.
But in reality, I know these guys, these students, and I've been around them, aren't that way. And but they're incredibly service-minded. And in talking with Dr. Gerard, I suggested to him that we could graduate these students early, get them out on the front lines, particularly in rural areas. As the chairman of the National Rural Healthcare Task Force, having working physicians and also ancillary personnel, everything from respiratory techs to nurses, is usually in short supply. And in one of these sorts of situations, one coronavirus could contaminate an entire hospital, local hospital. Mm-hmm. So the need for a surge capacity is huge. Many of these are underserved already, and many of these students have actually spent a month or two in a rural environment. And so what we wanted to do was try to get them out to work with the local hospitals, federally qualified health centers, and with other providers, other physicians, so that they can free resources up in a lot of different ways.
Well, Dr. Collier, I just want to say thank you, and thanks as well to Dr. Doug Gerard, our chancellor at the University of Kansas. Doug is an ear, nose, and throat physician. And then Rob Samari, our executive vice chancellor. Rob's is a cardiologist. And just to say, both Dr. Gerard and Dr. Samari still see patients. And Dr. Ojo, our dean of the School of Medicine, who is a nephrologist and also seeing patients. So, it's just a remarkable team of people who have come together to do this. And so, Jeff, thank you very much for helping push this idea, get it started, and help us make those connections across Kansas.
Yeah, no, this is going to be a national model. It is really exciting.
It is exciting. So with that introduction, and we're open to questions from reporters, and tell us what questions you have.
Can you talk about how the drive-up specimen locations are going so far?
You bet. So we do have some drive-up locations, and they're busy. We're doing between 50 and 100 of folks a day. We have been doing our own healthcare providers to check when they have symptoms to make sure that we don't have them infecting folks, and KU patients who are in special disease classes, like you've had a heart transplant or a lung transplant or a liver transplant, et cetera, or other diseases where you may be immunocompromised. We have not done drive-by. We did originally to all of our patients who had symptoms. We've had to restrict this because of the supply of tests and testing kits, and specifically the swabs. Our capacity is starting to increase, and one of the things we're trying to do is make sure that we were able to reduce the number of people under investigation inside our hospital, because at one point we were in the mid-50s around that, and we have to treat all those as if they had COVID-19, and because of that we were draining our infectious control supplies. So our first priority was to try and determine as rapidly as possible whether people had COVID-19 or they did not, or had the SARS-CoV-2 virus or not. And now that we're able to do that more rapidly, and we're looking at getting increased testing, we're talking about other ways we can help testing and help our county health departments, Johnson, Wyandotte, and others, help other healthcare institutions, and especially help first responders to determine if they have been exposed or not. And so that's going to be our next wave as these new testing methodologies come online over the next few weeks.
What's your hope with these drive-up? Do you have a goal here in the next week or so, like you had talked about with maybe even first responders if they're able to come up? What's your hope for it?
Our hope is that we're able to do that. We have to make sure our testing equipment arrives and our swabs arrive. Mm-hmm. And if those two things, well, the testing equipment, part of it's already here. It's up, installed, working, and it meets all our testing validation criteria. If that's true and we have enough swabs, then we will open it up. We're already opening many of the first responders now, but we'll even be more broad around the area, because our goal is to, ultimately we'd love to test as many people as we can. But we just have to make sure our supplies back that statement up. Next question.
I'm sorry, could you explain a little more about the early graduation? So what are these students missing in terms of their education by graduating early? And then how do you ensure that they go to the places, such as rural places or wherever they may most be needed in terms of surge capacity?
You bet.
Wow, those are excellent
Kennedy,
questions.
those are great
Yeah.
questions.
Absolutely. We don't want the students to miss out on any of their education. And so, therefore, many of these students, by the time they match, have already completed most of all of their graduation requirements. And that was one stipulation that we put out for those students. So we actually have two sets of students, those who are available now because they've completed all their graduation requirements, and then those who are yet to complete them, but by the end of April will be ready. And then once they're identified as having completed all the requirements, then that makes them eligible for this early graduation. And then those degrees will be conferred early. They will have the MD degree. And then Kansas has a unique program in that we have a special permit through the Board of Healing Arts for students to work on a temporary basis with a supervising physician. So they'll still be supervised, and they'll complete all of their graduation requirements. But rather than have them sit around for a month or two waiting, usually what they do is transition to their new town where they're going to do residency. The other question about matching them to places of need. So we set up through the Kansas National Guard, Dr. John Alley, who's a general surgeon here at KU Med. So he has been called to duty, and he will be the director of pretty much the operational portion of this. And then we also have enlisted the Kansas Medical Society, the Kansas Hospital Association, and the Kansas Academy of Family Physicians to put the word out to their members, so hospitals and physicians throughout the state, and then funnel all that need through Dr. Alley, and then we will put the students together in terms of where they'd like to go, but offer them a position. We don't feel like it's prudent to force them into any of this because they're a volunteer. So if it's a situation they're not comfortable with, then we'll negotiate that. But that way we match need with available students.
And Mike, if there's a big need, let's say in Wyandotte County, Johnson County, could a student even go there?
Absolutely.
Yeah, this
absolutely.
is great. So Jeff, can I ask a quick question? Sorry, media, I want to ask my own question. So Jeff, what were you doing when were you on the back porch? Where were you when this idea kind of popped into your head? Give me a little bit of the sense of how this came about. Were you in the operating room? What were you doing?
Yeah. Actually, I was actually in my car on the way to an emergency room here in town, and I've been the last month. I was appointed chairman of the National Commission, and remembered a great experience I had as a medical student working with Dr. Gary Sinning up in Hiawatha, and I had spent a month with him. And as you know, I work in lots of conflict zones around the world, and have worked in about 25 different war zones and epidemics, from Syria to the Rwandan genocide. And even when I was a senior med student at KU, I spent the last 5 months or 4 months of my residency, including match day, in Afghanistan during when the Soviets had invaded Afghanistan, and working along the border there with an organization called International Medical. But I'm talking with med students every single day, and this particular group of medical students, these seniors, the whole KU student body, they're very interested in service. They want to help. They're personally driven, and they're out there doing things. And this is a for them to really get out and help augment our most needed places at a time which is unprecedented in the state of Kansas.
Yeah, it really is. And for those that you don't know, Dr. Collier has done a number of medical missions, as he highlighted here, a remarkable number around the world. Next question. I'm not hearing a question, which I get to fill it then. When you don't ask a question, I get to ask questions.
Actually, I do have a question. I was just trying to take off my mute so everybody didn't hear my kids and dog in the background. This is Angie with KCTV5. Good morning. So the FDA has approved an antibody test. Can you talk about how important that will be and what hopes you guys have for that to figure out maybe if somebody has already had coronavirus and beat it?
You bet.
Yeah.
Dana?
Yeah, definitely. I think serology or antibody tests are definitely needed. I think right now in the acute phase, or to diagnose acute infection, I still think that the nucleic acid, the test that we're doing now, is better for that. I think moving forward, possibly using the serology or the antibody test will be helpful, but I think it's mostly going to be helpful to really understand the prevalence of this infection, meaning how many people were infected and maybe didn't know, how many people were exposed and maybe didn't know. By doing these tests, we can better estimate the overall prevalence and the epidemiology of this disease. Right now, for the acute phase that we're in, with the ascent of the infections and the need to prepare for the surge, I think still moving forward, the best test that we have to look at acute infection and acute illness is going to be the nucleic acid test. But I definitely believe that the antibody test will be helpful and provide very good information in the future.
And Dana, do you think that there will be a role for pooled antibodies from patients who have recovered? Because that's really what the antibody test can also be used for, I think, is to develop serum that would then be able to be given to patients who have the disease from a pool of people who have recovered from the disease.
Yeah, that's very interesting. I certainly believe that the convalescent sera or the pooled sera of people who've recovered from the disease who have antibodies is probably very promising because we've seen that work in other diseases. The other question is, well, when do we give the pooled sera or the pooled antibodies? Because it's still really unclear what happens later in disease, say 7, 10, 14 days after somebody gets infected. Does the virus fully clear, and what makes you so sick? Is it your cytokine storm that we've heard about in the media? Is it your immune reaction? So we really still have to figure out the best timing to use that convalescent sera or those antibodies. But yeah, I think moving forward, there's going to be hopefully an abundance of uses for this test. Just right now, in diagnosing acute infection, still we are using the nucleic acid test. But I think moving forward, it will provide us with a lot of data and a lot of information to use.
And there are some trials looking at using pooled serum across the country right now.
And I think
we hope to jump into soon.
I think those will be very helpful.
Yep.
Another question on that. Have you guys heard? Oh, do you mind if I ask a quick follow-up?
You bet.
Sure.
Go ahead.
Okay, thank you. I know there's been some discussion among people questioning if maybe they had coronavirus. Is that something that you guys have discussed at the hospital, that when you look back, that perhaps in February there were some patients who had corona? Can you tell me about the discussions that have taken place inside the hospital?
You mean for with staff or with patients or?
No, just maybe with patients in general. We're people who were sick, and then you test them and they don't have the flu, and then you treat them as if they had the flu because my gosh, they're so sick. So can you talk a little bit about that? Because I think that's something a lot of people have questioned themselves. If my gosh, maybe what I had was coronavirus.
Yeah, and that may well be true. Especially in folks who are younger and the very young, they may not even know they had it at all. For people that's 5, 6, 7, 8 years old, teenagers may have a very mild set of symptoms, even to the 20-somethings. And I think that's I'm afraid that that's actually pretty common, and that's one of the concerns about folks being vectors, is because you're a vector because you don't even know you're sick or you have very mild symptoms. So when that happens, that puts everybody you're around at risk. That's why social distancing is so important, and this shelter at home is so important, is that you don't have as many people to spread it to when you do that. And that's why we always come back and emphasize it, because it can be very silent or very quiet in some patients. Now, in older folks, people like my age or Dr. Collier's age, we tend to have more symptoms. Yeah, sorry about that. We did graduate the same year. You were a Jayhawk, I was a Tiger back in med school.
Yeah,
so,
and Rob Smurray was in there too.
He was. That's right. We have a bunch of people in that class that are currently here. Dr. Camerata, chair of neurosurgery.
Camerata.
Yeah, this is Dr. Delcor, chair of surgery. So. But I think what happens when you get older is you tend to have more symptoms, and when you have more symptoms, a little more clear, and you can get tested. There may well have been people who had the disease, though. This disease was probably in Kansas, in Missouri back in February, maybe even prior to that, but probably, well, for sure in February. And there may have been people we just weren't testing at that point as much. And so you may have had it, we didn't know, you tested negative for the flu, and we wouldn't have taken another step. You would have just said you had some virus. So you may have had it. And the only way to do that then is to use that convalescent serum. That after you do it, we can check your antibody levels. Early in a disease process, there's one kind of antibody. Later in a disease process, there's another kind of antibody. And what we know is that, or what we hope to know is that we can find the serum from patients who recovered and didn't get that sick and give that to others to help prevent illness. And that's the part that's the part that's still the study. Now, there was another question out there, I think, too, right?
Yeah, Celia with Kansas News Service. I was just wondering what you guys are hearing about false negatives, accuracy issues with the nose swab type tests. I'm sure you saw the op-ed in the New York Times from a Yale physician concerned that doctors are seeing a lot of false negatives for COVID-19. Is that a concern that you guys are looking at? And
it is.
So what do we do about it?
And Dana's going to talk about that. I'm going to give the same plea I always give. So much of the data, there's a question of how you collected the swab and how the swab gets run. I think the biggest variable is in how people collect the swab. I don't know how many of you ever had a flu swab, but the swab that's used for the flu is actually the same one that's used for COVID-19, and it's a real bristly thing. And when you put it in, I'm just going to tell you, it hurts. It feels like you have a brain biopsy. If it doesn't feel that way, it wasn't collected correctly, and that's one of our challenges, especially in the hands of people who are less experienced. They don't do the swab right, or the patient says, "Oh, that hurts, don't do that," and then we stop because it does hurt. Yeah. But the reality is that unless you've done the test correctly on the swab, you can have the best instrument in the world, and it doesn't help you. In the future, we are very hopeful there will be salival sampling. If we can do that, then it's going to be a lot easier. But we're not sure how sensitive and how good those instruments are yet. So Dana, thoughts? I know we've done some internal looks to verify how well our instruments are working with good swabs.
Yeah,
tell us about that.
If I can give those numbers. So to echo Dr. Steich's point, you're putting essentially the swab back to about where your ear is through your nose. So it is almost like a brain biopsy. It feels
like it's like 100 yards.
And if you have,
that's much longer than that.
If you have a nice nurse who doesn't want to hurt you, that could be a problem because the sampling may not be good. But as far as our internal numbers, that has been a question. That's always a question in any test we run. What is the sensitivity and specificity? What is the chance that I'm really going to pick up a true disease, and what is the chance that I won't pick up somebody who doesn't have it? That's always a concern for any test that we run as physicians. But just from internal numbers, from our recent tests that we're doing in-house, we have tested at least 34 unique patients more than one time. 33 of those were negative both times, and one of those was positive both times. So that would tell us that our sensitivity and our specificity and our negative predictive value and our positive predictive value for this test are at this point very good. I would like to emphasize again, a lot of it could be operator error in making sure that we get the good sample.
We have a question that has come into me about daycares. They're saying that, they're not very full. And if you hadn't used that daycare and now suddenly they have an opening, is it safe? And what should a parent look for?
Is it safe to use daycare that may not be very full? Man, Dr. Hawkinson, I'm so glad you're here today to answer that question.
That is a tough public health question. And I think that's what it comes down to, is public health. Just because we understand that luckily, for the most part, children are spared. Now, that's not to say they can't get severe disease. They absolutely can, but certainly in a much, much, much lower proportion than older populations. but they can still have symptoms. They can still spread the disease even though they have mild to even no symptoms. So that's a very good public health question. But that can happen with any virus, influenza, any other cold virus as well. That's a hard question to answer. I think that in this time period, certainly if you don't have to use daycare, and I know that these circumstances are a lot different than they were 4, 5, 6 weeks ago. If you don't have to, I would probably try to advise not to use daycare or other places where you're being with other children, but also those households, those parents that are coming in, bringing their kids, things of that nature. So I think you just open yourself up to be having contact with more outside households and possibly bringing the disease home.
And just remember, the kid may not be sick,
right,
but they can make you really sick. And if you have a parent or there's a grandparent or someone else or anybody who has other diseases, health diseases, boy, they can really be at risk to that. So, other questions? So, Mike, as you've looked out across Kansas and seen what's going on, or Dr. Collier, any ideas where you think students will be the most useful? What's your sense about where we need to do the most work?
Well, I have done kind of a straw poll of various hospitals that I work with on a regular basis, and pretty much the eastern 1/3 of the state is actually where the highest numbers are right now.
Yes.
And I think those are the ones who have been asking for help. The FQHC in Pittsburgh said that they were fielding 400 calls daily. And that would be a great thing for a volunteer medical student to do, would be to field those calls and alleviate some of the fear that people have. Mm-hmm. Another hospital has, I just heard this morning, has 10 inpatients. Half of them are COVID positive. And in a small 20-bed hospital, that is
overwhelming.
That's overwhelming. It's devastating.
Overwhelming.
And so, they're looking for ways that they can free up their regular staff so that they can do the work of caring for those patients. By the way, they have 22 cases in their nursing home, mm-hmm. which is absolutely nightmarish in terms of that situation. So I think the biggest need is going to be in the eastern 1/3. Fortunately, that's pretty close for these students. Yeah. But we do have far west parts of the state that are starting to feel the pressure from this, Dodge City, Great Bend. So there's several of these now that have cases, and so we'll just have to wait and see. I'm afraid that peak will be delayed even further, right?
I think it is, and we think it's going to, some of this will stretch well into May as far as some of the peaks as it moves across Kansas, in part because just based upon density, there's already a lot of social distancing, but it doesn't mean you're immune to it or that will protect you, because all the things that operate around infection control are true wherever you go. Dr. Collier, any other thoughts from your standpoint about where the greatest need in Kansas will be?
Yeah, so we see the picture shifting, nationally, and there is some natural spread, that's heading out into rural areas and across the state. There's also, one of the things is medical students oftentimes can be used for other things. They may be able to augment the local doc and see some of the less acute patients and help them and work in conjunction. And then sometimes you just need somebody to go and draw the blood and get this going because maybe staff is too busy, or they may be out, or run an EKG and other things. So there really can be kind of a jack of all trades. And that's important, and they're energetic and they're rarer to go.
Can I ask one other question?
Please.
do you guys have any advice for reporters as we try to understand and give our readers and listeners a picture of just how full Kansas hospitals are? You know, there's modeling out of Harvard, there's modeling out of University of Washington, but what should we ask? You know, Stormont Vail is putting out kind of like a daily scorecard almost, like to say, this is how many ICU spots we have, and this is how many are full. Is that what we should go to hospitals and ask to see whether we're getting to that point of overflowing?
Yeah, that is a great and fair question. So what I can tell you is that there's a number of groups working through the Kansas Hospital Association, KHA, to build a dashboard that we'll show on a daily basis. So I would probably go to KHA and visit with them about when that might be ready. You know, we put our numbers out there, as you know, at the beginning of this media presentation every day, and we'll continue to do that. We post them to our medical staff and our hospital staff that work here, health system staff. And I think you're going to see that will rise. I'm fortunate enough to be on a number of calls with the KDHE and different CMO calls. I wouldn't say that anybody's overwhelmed yet. I think everybody's arming for the battle, and they're starting to feel the skirmishes. There are some individual places, like Dr. Kennedy referenced, that are probably a little overwhelmed, maybe even a lot overwhelmed by that. But by and large, we still have capacity. The next 2 weeks are just pivotal. And so with that thought, what I want to do, we're kind of hitting our time now. I want to go ahead and offer or ask for some closing comments, and I have one as well. But I'd like to start with Dr. Collier.
Yeah. No, I just really appreciate all the service that people have done. And reporters, what you don't understand is if we were going to try to do this any other time, it's sort of taken 2-3 years to get through, to get the Board of Healing Arts, to get the finance, to get KU, to get the students, to get the program going. And doing this in 2 weeks is truly amazing out there. And I just appreciate everybody's tremendous service in this.
Dr. Kennedy.
So I want to thank the student volunteers. And, you know, they're from all 3 campuses. KU has a unique system in that we have a main campus and 2 branch campuses. All of the people who helped to put this together, and thank you, Dr. Collier, for the idea. And then I also want to thank the Patterson Family Foundation, who has made a generous contribution of $1 million to fund this initiative, which is absolutely remarkable. And so with that, I'm hopeful that you know, in Kansas, these rural physicians will get the help they need, and they don't have the surge capacity, and I think to avert a disaster, we need all hands on deck.
Dr. Hawkinson.
Yeah. Well, it is Friday, so as we move into the weekend, hopefully that will help people. We have to remember this is a physical, but also this time is a very emotionally and psychologically draining time as well. So please try and find a healthy space, something healthy to do. Try and stay home. You know, if you have to meet with 1 or 2 other people, okay, but do that outside. Maintain 6 to 8 to 10 feet away. Do not meet in groups. But if you can get outside, absolutely get outside, but do it in the smart way, in the way that we've been preaching and asking you to do, because we really do have to try and bend this curve and flatten it and try and stop the spread.
So I want to talk about all that. I want to talk about Purell. Only this morning, it's not Purell. It's Rieger's.
Uh-huh.
They made hand sanitizer for us. It's for those of you who don't know, Rieger's is a company here in Kansas City that makes their own gin and whiskey. It's great. Of course, I don't really drink very much, but that's really good. And you can't drink their hand sanitizer, just to be clear. But you think of all the things that people are doing. The Patterson Family Foundation with $1 million gift. Our students volunteering to go out and work in the front lines in rural Kansas. Healthcare workers who are out there every day, our nursing staff. No one is more exposed than our nursing staff, who valiantly go there and rise up and go to the bedside every moment of every day. Rieger's Liquors, who turns and makes takes their alcohol and makes hand sanitizer. And I used it this morning. I'm like, that's different. That's the Riegers one. So thank you. To Design Innovation, who made face masks for us and face shields. There are so many good people and so many folks out there that are trying to help. We need your help as well, right? We need your help as well. The way to beat coronavirus, it's not a superhero, right? Remember we said that yesterday. Not a superhero. Doesn't have wings, doesn't have legs. If you shelter at home, you stay 6 feet away, you wash your hands, and if you don't touch your face, cough into your elbow, we will beat coronavirus. And we'll do it because we all worked collectively together to make that so. So remember, there's no place like home. Thanks for your help today. We'll talk to you all soon.